Guys, good afternoon. Today I will be discussing respiratory, okay? Cough, cough plus or minus haemoptysis, shortness of breath, okay? So, cough plus or minus haemoptysis and shortness of breath, okay? Let's start with cough. So, as a presenting complaint, the patient presented with cough, okay? And I will discuss cough plus or minus, haemoptysis in case the patient presented with haemoptysis. Okay, how can I help you? Doctor, I have been having some cough. Doctor, I have been coughing. Is it medicine or counseling? Is it medicine case or counseling case? Is there any diagnosis here? No. So it is medicine case, okay? In medicine cases, the structure is P1, P2, P3, maftosa. However, presenting complaint is cough. So how can I help you, doctor? I have been coughing. So, can you please tell me more about it? So explore the cough. Be careful, because if the cough is for long periods, if it's 3 weeks or more, you will be thinking of some differentials. If the cough is less than 3 weeks, 1 week, 8 days, 5 days, 6 days, you will be thinking of some other differentials. However, forget about this now, but I will tell you, if the patient is presenting and the cough is for a long time, if the cough is quite chronic, you will need to exclude some specific differentials. Anyway, for now, how can I help you, doctor? I've been coughing. So explore the cough. How do I explore the cough? The cough, exploring it through Odipara. Forget about Odipara. When did the cough started? When did the cough start? For how long? Doctor, 5 days, 6 days. Acute or all of or gradual, increasing or the same since it started. Okay? And if the patient is giving you chronic cough for about 3 weeks, 4 weeks, make sure you ask psychosocial, because the patient who's been coughing for a while, maybe the cough is affecting his sleep. Maybe he can't sleep. Does that make sense? Because if you're coughing at night, you can't sleep. So, explore the cough. And when you explore the cough, use Odipara. And we know what Odipara is. Odipara is how to explore any presenting complaint apart from chest pain. Chest pain, Socrates. Everything else is Odipara, which is onset, duration, intensity, progression, anything that makes it, anything that's relieving it, okay? Timing. So, please, whenever you explore the presenting complaint in details, after you explore the cough, you have to ask him, is there any phlegm? Is there any phlegm? Is there any phlegm? Or is there any sputum? If the patient said yes, doctor, there is a sputum, or yes, doctor, there is phlegm, how to explore sputum or phlegm? Track. T for timing. When did the sputum started? Is it with the cough from the start or later? R, relation, do you think it's related to anything specific? A, amount, how much? Teaspoon, big spoon, you understand? C is color, which means, does it have any blood? And if you said there is a blood, you need to explore, is it the sputum have strikes of blood, or it's actually frank haemoptysis, all of it blood? Does that make sense? So if the patient said there is blood, you need to know how much blood in it. Is it a sputum with strike? Sputum with a strike of blood, lines of blood, or is it frank haemoptysis? Does that make sense? So this is for exploring the cough. So whenever you explore the cough, make sure you ask about sputum. So is it productive or dry? Okay? So I've asked about the cough and the sputum or the phlegm. Now, I will ask my patient anything else apart from the cough. Any other symptoms? If the patient said no, or if the patient said like what, then you start asking. I always tell you that there are 5 symptoms that they come together. 5 symptoms that come together. Cough, shortness of breath, chest pain, and heart racing, palpitation, and trauma. So 5 symptoms that come together. Cough, shortness of breath, chest pain, heart racing, which is palpitation, and trauma. So apart from the cough, and fever, don't forget fever, yeah? So apart from the cough, any other symptoms? Like what, doctor? Then you have five fixed symptoms. Like any shortness of breath, any chest pain, any heart racing or palpitation, any fever. So five symptoms, they come together and they are differentials at the same time. These five symptoms, we consider them as differential. What do you mean, doctor, differential? So whenever the patient is having cough, ask about these four. Whenever the patient is having fever, ask about this. Whenever the patient is having shortness of breath, ask about the five, they come together. But if the patient gives you a positive finding, do you leave it or explore it? Please explore. So if the patient said, yes, doctor, I have fever, tell me more about it. When did it happen? How did it happen? Did you take anything? Did you measure it? What was the measurement? When you took the medication, is it relieved? So explore, yeah? So after exploring the cough, after exploring any other symptoms, now let's think. I will tell myself during the station, I'm not gonna stop, but I will tell myself, is the cough chronic or is the cough acute? Is it some sort of acute cough, 5 days, 6 days, which I'm suspecting high possibility of infection? Or is it a sort of chronic cough, chronic, 4 weeks, 3 weeks, 3.5 weeks, which I'm suspecting cancer? So now, after cough and after the five symptoms, right away you need to have flows. You need to have what? You need to have what? Flows. Dr. Mo, what do you mean flows? Flows, F for fever, L for lethargic, A for loss of appetite, W, weight loss, S, night sweat. Night sweat to exclude what? TB. So TB, they have night sweats. Yeah? Weight loss, typical cancer, malignancy. Appetite, again, loss of appetite, malignancy. Lethargic, fever. Fever is there and fever is here. But right away, when you explore the cough, I will put the five symptoms. After the five symptoms, flows. Guys, by this stage, you are safe. Safe to go. What do I mean by safe to go? Safe to move on to the rest of the history without even differential. Are you sure, Dr. Mo? Yes. In these cases here, from what I've mentioned, the cough, did you exclude pulmonary embolism? Yes, because PE comes with haemoptysis. Cough, haemoptysis. Yes, I did exclude shortness of breath, chest pain. Okay? Did you exclude with this cough any infection? Yes, why? Fever. Did you exclude cancer? Yes, flows. So by this you are safe. You are safe. So while you are taking history, if the patient gives you weight loss and fever and night sweat with the cough, you're thinking of TB. So you don't need to go into more differential. Please, maximum 4 differentials. Maximum 4 differentials. Then, after that, I will go to P2. What is P2? Past history of presenting complaint and past medical conditions. Past medical condition. Okay, what do you mean, Dr. Mo, past history of presenting complaint? Presenting complaint is cough. Have you had cough before? Have you had such a cough before? Have you had similar cough before? Past medical condition. What are the medical conditions I should ask about? 5 medical conditions. Always, all the time. I will ask any medical condition like diabetes, like high blood pressure, like any cholesterol problem, and so on. Now go to P3. What is P3? What is P3? P3 is DASA plus or minus IV drug abuse and sexual history. Again, what is P3? P3 is lifestyle questions. So it is DASA plus or minus what? IV drug abuse and sexual history. So DASA, diet. Is diet important in cough? No. Exercise. Is exercise important in cough? No. Smoking. Is smoking important in cough? Yes. So I will ask smoking. Smoking is a must. So from all DASA, something that is a must. You need to be relevant. We need relevant history. What is the meaning of relevant history? Relevant history that related to the case. So I save my time, so I move into management. So smoking is a must. Then come to IV drug abuse and sexual history, must. Wow, must, yes, must. IV drug abuse and sexual history is a must. Why is a must? Because I have PCP, which is pneumocystis carinii pneumonia. It's type of pneumonia that it's in HIV patient. HIV patient, so sexual history and IV drug abuse. Yeah? So IV drug abuse and sexual history, must. Smoking, must. Diet, don't bother if you don't ask. Exercise, don't bother. Exercise will be important in exercise with asthma. If the patient coming with short on breath. But in this case, it's cough. Cough stations. Haemoptysis. M. What does M stand for? Medications. Medications. Are you on any medications? It's very important the question because medication side effect. AC inhibitors. AC inhibitors like enalapril, ramipril. Main side effect is dry cough. So always ask, are you on any medications by any chance? Why? Because medication side effect can cause cough. Maybe this patient is having dry cough and is coming and is on medication for which is causing the cough, which is AC inhibitor. Allergy. Do you have any allergy to anything? Very important because allergy can cause cough and shortness of breath. Yeah. Family history. If the patient is coming and I am I'm asking about cough and he give me positive history of cancer, like weight loss, cough and blood in the sputum. So always don't forget to ask family history. But please guys, you are asking about family history of what? Of cancer. So please don't just ask like this. Try to signpost. I'd like to ask you some question that may sound quite alarming. Please bear with me. It's a part of my consultation. Yeah? Anybody in the family has been diagnosed with cancer? You understand me? So always try to put sign posting, please, yeah? Then T is for travel. Is travel important? T, travel. Is travel important? It is a must. Travel and contact. T is for travel history and the contact history. Please, you must ask about travel history and the contact history. You must ask about travel history and contact history. So, from all what I have mentioned about cough, how can I help you? Doctor, I have cough. Tell me more about it. Explore cough in details. And cough, and always cough, whenever there is cough, ask, is it dry or there is phlegm? Ask about the phlegm in details using track. Track is the term that I use to explore any secretions. Rhinorrhea, anything comes out of my body, if I want to explore it, I use track. So just a little thing about Odipara and Socrates and track. Socrates, only I use it to explore the chest pain. So Socrates is only used to explore whenever the patient is coming with chest pain, I use Socrates. Odipara is whenever I explore any other symptom apart from pain. Track, any secretions, vomiting, diarrhea, I use track. Timing, relation, amount, color. Then, after finishing the cough, there are always 5 symptoms they come together, which are cough, shortness of breath, chest pain, palpitation, and fever. Whenever there is one, I ask about the rest. So I will ask the rest and then flows. After flows, I will go to P2. Have you had this before? Medical condition. Then P3, which is DESA plus or minus IV drug abuse and sexual history. Sexual history and IV drug abuse is a must in chronic cough. Okay? And Haemoptysis, M for medication, medication side effect. Be careful. One of the cases might have medication side effect. A allergy, F family history of cancer, if there is you suspecting cancer. T, travel and contact. T, travel and contact. Don't forget Haemoptysis. What does O stand for? Occupation is very important. Occupation, we know mesothelioma, okay, in patients who've been working where? Asbestosis, and people who've been in the sea, working in the sea for a while, so wood factories. So please, occupation is very important. Occupation is very important. Occupation is very important, okay? And that's it. This is the cough and Haemoptysis history. Now let's talk about the cases one by one and management. Does that make sense? So the cases one by one, I will mention the case. You know how to take the history. All of them will be cough and Haemoptysis. However, I would like to give you a note, small note. I I'd like to give you a small note about if the patient is coming and he tells you, doctor, I have haemoptysis, there is bleeding in my sputum, please make sure you check the observation, because you want to know is the patient is stable, hemodynamically stable or not, because there's bleeding coming out. Yeah, so let's go quickly with the history. Okay, let's go quickly with the history. We said whenever the patient is coming with chronic cough, what should I think of? How can I help you, doctor? I've been coughing for more than 3 weeks. What should I think of? Differentials, causes for chronic cough. The history will go the same or will be different? The history is the same, but what should I think of? I will think of lung cancer. Lung cancer. Smoking is a must. Bronchial cell carcinoma, bronchogenic carcinoma. Smoking is a must. If you don't ask about smoking in a patient who's having chronic cough, you lost it. I will ask about occupation is a must. Occupation, I'm recapping, yeah? Occupation is a must. Why? Because I'm thinking of mesothelioma. I will ask about travel history and contact history is a must. TB, because we know from Lab 1, if you travel to some countries, high possibility of TB. I will ask about IV drug abuse and sexual history because of PCP. So how many cases I have mentioned now if the patient is coming with chronic cough? Number 1, bronchogenic carcinoma, ask about smoking. Number 2, mesothelioma, ask about job, occupation. Number 3, TB, ask about travel and contact history. Number 4, PCP, ask about HIV, which is, PCP is pneumocystis carinii pneumonia. Common HIV patients ask about IV drug abuse and sexual history. Is it clear? This is a map in your head. But I will follow the same history. I will explore the same way, but you will be thinking of 4 things if the cough is chronic. So chronic cough, can you tell me the 4 conditions we said in chronic cough?
Chronic cough,
Bronchogenic carcinoma, mesothelioma, TB, PCP. And we know that every one of them has a positive thing, okay? If the cough is less than 2 weeks, for example, acute cough, I will think of what? I will think of pneumonia, PE, and pneumothorax, because pneumothorax can come with cough, shortness of breath. The patient cannot take breathe, yeah? But the most common that I want you to think of is the pneumonia. So if the cough is acute, what should I think of? Pneumonia, main thing. What should I think of? Pneumonia. If the cough is acute, infectious, pneumonia. If the cough is acute, I can think of PE. Can PE lead to cough? Yes. PE can lead to cough. Pneumothorax, yes, cough and shortness of breath. Can I think of children? Now, if it's acute cough in adult, 3 P's. 3 P's. Pneumonia, PE, pneumothorax. Okay. If the cough is acute, I will think of 3 P's. Yeah? Pneumonia. What is the presentation? Cough and fever. Yeah? Cough and fever infection. PE, presentation. Cough, chest pain, and sometimes haemoptysis, guys. Okay? Cough, chest, pain, and sometimes haemoptysis. And the patient will have DVT. The patient will have a history of travel, long travel, being on a plane for a while. The patient will be female, having oral contraception, okay, or HRT, any estrogen. If it's a children coming with cough, think of foreign body, bronchiolitis. Foreign body or bronchiolitis. And finally is asthma. So let's take this off now and just give you the differential in an easy way, how to think and what is the positive. So cough, assalamu alaikum, alaikum assalam. Cough for how long? Is it chronic or is it acute? Chronic more than 3 weeks. Chronic more than 3 weeks. What should I think of? 4, 1, 2, 3, 4. By the way, should I follow the same structure? Guys, these are the differential. These are the differential. But again, if the patient's coming with cough, how long? Explore, tell me more, ask about the other symptoms, the 5 symptoms that they come together, then flows. But now is how to reach your diagnosis. If it's chronic, I'll think of 4 things. Number 1 is a lung cancer. By that I mean bronchogenic carcinoma. Make sure you ask about one risk factor, very important, is smoking and also family history. Yeah, smoking and number 2, mesothelioma. Mesothelioma. One risk factor, occupation. Yeah, occupation. Number 3,
TB.
third, TB. One risk factor, travel history and the contact history. Travel and contact history. Finally, PCP, pneumococcal pneumonia. Always think of IV drug abuse and sexual history. Guys, so far so good. Come now to the acute cough. Acute cough. 3 P's. 3 P's. 3 P's. What is doctor? What is the meaning of 3 P's? Pneumonia. Pneumonia. And PE. And pneumothorax. Pneumothorax. Pneumonia, PE, pneumothorax. Then, if it's children, think of foreign body and bronchiolitis. Bronchiolitis case is being discussed already in pediatric. You don't need it. Foreign body case has been discussed already. You don't need it. 3 P's, pneumonia, PE, pneumothorax. Pneumonia, PE, and pneumothorax. Pneumonia, the patient will come with cough and fever. PE, the patient will come with cough, shortness of breath, sometimes chest pain, but be careful to ask about, you need to ask about long travel and what else? Pain in the leg, which is DVT, and what else? Medication, like what? Like OCP, it's one of the risk factors, like HRT, yeah? Medication, estrogen. Pneumothorax, history of trauma. Pneumothorax, history of trauma. That's it. And asthma is one of the acute cough, which will be discussed later. Clear, guys? Now, management. And all of them, any patient is coming with cough, will follow the same trend, the same structure. Flows, the 5 symptoms, the P2, the P3, the maftosa. But with every single station, you will have one positive. Okay? Okay. Guys, if the patient is coming with haemoptysis, cough and haemoptysis, what is the meaning of haemoptysis? Blood in sputum. If I need to add some risk factors, if the patient is coming with haemoptysis, doctor, sputum with blood, don't forget to ask about blood thinner. Don't forget to ask about bleeding disorder. So what are the most common causes of haemoptysis? Sputum with blood in it. What are the most common causes? If there is a sputum with blood, don't forget to ask about blood bleeding disorder, blood thinner. What else can cause haemoptysis from all of this? PE, guys. PE causes haemoptysis. So if I have haemoptysis, I will ask about bleeding disorder, blood thinner, PE. What else? Instrumentation, like bronchoscopy, maybe can cause cough. Instrumentation, and don't forget lung cancer. Don't forget what? Lung cancer. So 5 top differential if the patient is coming with haemoptysis. Doctor, guys, all this is to brainstorm your differentials. If the patient is coming, doctor, I have haemoptysis. Doctor, I'm having sputum with blood in it. There is blood in my sputum. What to think of? Risk factor, bleeding disorder? Yes. Is he on any blood thinner? Number 2. Think of PE, it could be PE. So then you can ask about long travel, medications, pain in the leg, okay? Think of number 4 is for instrumentation. If there is bronchoscopy, instrumentation, any instrument can cause cough, which has got bleeding, spitting blood. And finally is lung cancer. Finally is lung cancer, which are, I can take this off, and I can put here the causes of cough with Haemoptysis. Causes of cough with Haemoptysis. Causes of cough, because today I'm discussing only cough or cough and Haemoptysis. Cough and Haemoptysis. So cough and Haemoptysis. Causes of cough and Haemoptysis. Top differentials. 1, 2, 3, 4, 5. Cough with Haemoptysis. First cause, if the patient is on blood thinners, and that will be asked on medication history. Are you any blood thinners? Second, if the patient has any bleeding disorder, and that will be asked in medical conditions factor. If the patient is developing now, he's having PE, and by that I will ask about, apart from the cough and Haemoptysis, do you have any chest pain? Do you have any shortness of breath? Because chest pain and shortness of breath with the Haemoptysis, one of the signs of and the symptoms of PE. And don't forget to ask about pain in the leg. Don't forget to ask about what? Long what? Travel. Long travel. Don't forget to ask about what else? Medication like OCP, any medication that contains estrogen. 4. Instrumentation like bronchoscopy. Instrumentation like bronchoscopy. Any procedure, any instrumentation can lead to cough and Haemoptysis. And finally, lung cancer can lead to Haemoptysis. So always ask flows. 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 Okay, so that's all about history of cough and Haemoptysis. That's all about history of cough and Haemoptysis. Now, let's talk about the cases. Bismillah ar-Rahman ar-Rahim. First of all, if you have a case of cough, chronic, more than 3 weeks, and you took history, you found family history positive of cancer, the patient is a smoker, heavy smoker, yeah? And the patient is coming with weight loss, cough, sometimes blood and sputum, you are thinking of bronchogenic carcinoma. Guys, are you following me? Am I making any sense? Can you confirm while you are in the GP clinic and you take this history, you found that? Can you tell him you have cancer? No. So the provisional diagnosis will be best case scenario and worst case scenario. Best case scenario, infection. Worst case scenario, something sinister or something serious. Like what, doctor? Like, I would like to exclude cancer. Okay. What is the management? If I'm suspecting cancer, what is the management? So, if the patient is in the GP clinic, you're suspecting cancer, lung cancer, fast track referral or urgent referral within 2 weeks to the respiratory team. So, urgent referral or fast track referral. What if the patient is in respiratory department and you are suspecting lung cancer? Then admit. Again, this scenario of lung cancer, I've just given you. The first scenario now, I will discuss now. So we are all focused. The first scenario we are discussing is what? Lung cancer. I said to you, history, we know the history. Yeah? History we know. Weight loss, smoking, family history. What is the management? Provisional diagnosis, best case scenario and worst case. Best case scenario, you cannot confirm a cancer, you cannot tell him cancer because cancer diagnosis only with scope and biopsy. So we'll tell him worst case scenario could be something sinister, best case scenario could be something simple like as simple as infection, worst case scenario could be something sinister like cancer, yes. But now, what is the management? If you are in the GP clinic, if the question said that you are in the GP clinic, you will do urgent referral or fast track referral within 2 weeks to the respiratory department. There in the GP clinic, when you refer him, there they can order. What are the investigations? Blood, guys, blood, don't forget. Go back to day 1. Whenever I'm talking in management, in the exam, whenever in the exam I'm talking about management, think of the 7 steps, please. So I will do blood. Yes, what is the blood? Infection marker, full blood count. So full blood count, infection marker like CPC, like CRP, yeah? And if there is a sputum, you will take a sputum, culture, okay? Urine, we don't need anything in urine. Stool, no. Imaging. In the hospital, they will do chest X-ray, and also they will do CT scan, abdomen and pelvis. Why, doctor, CT scan, abdomen and pelvis as well? To exclude any metastasis, because you're suspecting cancer. And they will do, the specialist will do bronchoscopy, which is camera test, and they'll take sample. So, if the patient is in the GP clinic, what is the first word that will come out of your mouth during the management? Urgent referral or fast track referral within 2 weeks to the respiratory department. Where? What is where? Where? In the respiratory department. In the hospital, they will take blood, full blood count, and infection markers, sample from the sputum to check culture, sputum culture, image, chest X-ray. They will do scans, CT scan on the abdomen and pelvis. They will also do bronchoscopy, which is scope and take sample. Okay. What if the patient is short of breath with the same presentation, cancer, I'm suspecting, but he's gotten the presentation in the symptoms, shortness of breath. You understand me? He's short of breath and you're suspecting cancer in the GP. Would you do urgent referral within 2 weeks? No, immediate referral, because he needs oxygen. Are you clear? Are we clear here? So I added only one presentation, which is the patient is short of breath. Would you wait 2 weeks? No, immediate referral to the hospital, because we need to give him some oxygen. Guys, are you lost? So what is the one thing I changed in the stations? Shortness of breath. What if the same presentation, lung cancer, but he presented to the respiratory department, not the GP? He presented to the resp department. What is the management if you're suspecting cancer and they are in the respiratory department? Admit, because he's here now. Would you refer him? He is in the department. Admit him. Talk to senior, because we'll need to run some investigation. Like what? Same. Blood, image, chest X-ray, CT scan on the abdomen and pelvis, and bronchoscopy. Camera test, take some sample. So guys, did you sense the slight changes in management or not? Doctor, what's your name? Dr. Ahmed, slight change from GP? No, there is shortness of breath. There is something acute here. No, immediate referral. No, he's in the respiratory department. So slight difference will make slight changes, okay? Okay. Because we all know that in GP clinic, they don't have any facilities. They don't have chest X-ray, they don't have CT scans, yeah? So we will refer. Okay, now, if the case is mesothelioma, the second case, no, it's mesothelioma. By the way, mesothelioma is aggressive form of cancer. Mesothelioma is aggressive form of cancer. So if the case is mesothelioma, what would you do? By the way, if the case is mesothelioma, the only management is palliative care. Is what? Palliative. So if I'm in the GP clinic, and I had the patient, this case is lung cancer, bronchogenic carcinoma. What is the factor? We said smoking and family history. No. Another patient is coming. Family history or smoking or whatever. No. The occupational history is there. Weight loss, cough, haemoptysis, appetite. I'm suspecting mesothelioma. In this case, again, can you give definitive diagnosis? Again, best case, worst case. However, if you are in the GP clinic, what would you do? Again, urgent referral, blood, scan, CT, yeah, everything. But the difference between mesothelioma and lung cancer is what?
No,
is the prognosis. No, still, you will offer bronchoscopy. Still, bronchoscopy, sample, still. The mesothelioma, the prognosis is very bad. So, palliative care. So, in mesothelioma, if the patient asks you, doctor, if it's a mesothelioma, doctor, what is mesothelioma, guys? Cancer of the pleura, okay? Cancer of the pleura. So, if it is, doctor, I'm afraid the only management is what? Palliative care. The only management. for mesothelioma is palliative care, which is, what is palliative care? It is basically you will be managed by a team, which we call it multiple disciplinary team, MDT, where they will make sure that your pain is relieved, where they will make sure that you are well looked after. They will support you psychologically and spiritually and emotionally, and they will make sure that you are pain free. That's the palliative care team. So that's the only thing that is different, is the prognosis between mesothelioma and lung cancer. But both of them will take the same pathway of urgent referral, scans, X-ray, CT, bronchoscopy, and bloods. Clear, guys? Diagnosis, best case, worst case. Okay? Okay. Now, the third very common cause is pneumonia as a cause of cough. Pneumonia as a cause of cough. Okay. If the patient is coming with cough and I'm suspecting pneumonia, what are the positive findings in history? So just to recap the history: cough, shortness of breath, sputum, fever. So these are the positive symptoms. So cough, shortness of breath, and sputum and fever. We know that pneumonia can come without sputum. We know that, dry cough, yeah? But just to recap the positive finding. Okay. If I'm suspecting pneumonia, the patient came in D&E, okay, clear? And I'm taking history, the patient's having cough, the patient is having fever, now, pneumonia, now I'm discussing pneumonia, okay? The patient came to me in D&E, the case is a patient is in D&E and have cough. I'm suspecting what? Pneumonia. Okay. What is the management? The management, simply, I have something called CURB 65. CURB 65. If I'm suspecting pneumonia, we have CURB 65, which will make me see, should I admit this patient or not? What is CURB 65? What is CURB 65? C for confusion. C for confusion. U for urea. R for respiratory rate. B for blood pressure 65. So confusion. If the patient is confused, that's 1. Every one of them is a point. Urea. If urea is 7 or more, is what?
7.
7 or more. If the patient is confused, we know. Do you know where you are? No. Do you know who brought you here? No. Can you confirm your full name? He can't. He's confused. 1 point. Urea 7 or more? 1 point. Respiratory rate more than 30. So 30 or more? 1 point. Blood pressure less than 90, systolic, or less than 60, diastolic, 1 point. 65 is age. 65 or more, 1 point. So every one of them is 1 point. When to admit and when to send home. When to admit, when to send home. 2 or more, admission. Think of it like this. Which is most of my cases for plateau? Think, focus. Most of my cases will be admitted. Okay? If the patient is confused, what do you think? From sepsis, septic shock, will admit? Does that make sense? So mostly will admit. But CURB 65, if it's a 3 or more admission, 2 is observe, less send home. But in plateau, most of my patient will be admitted. They will score 3 or more, admitted. Most of your patients admitted. And all my cases in plateau, mostly the patient will be confused because the most common cause of confusion is chest and urine. So admit the patient. Okay, now, admission or not, I will admit. What are the investigations? Think, investigation. Doctor, I'm coughing and I'm having sputum. Start again. Blood, urine, stool, please. Blood, urine, stool, image. So blood, full blood count, infection marker, liver function, kidney function, urea electrolyte. Why urea electrolyte? Because of curb. Okay? Curb 65. So we need urea electrolyte. Blood culture if the patient is confused. Sepsis 6. So if the patient is coming confused and cough, always blood culture, lactate. Chest X-ray, chest X-ray. Okay. So this is for pneumonia. Do I need to do PCR test? Yes, in some cases, if I'm suspecting HIV, PCP, HIV, PCP, pneumonia, or if I'm suspecting TB, I will need to check PCR test, okay? But if it's bacterial infection like, normal pneumonia, you don't need to. Normal, okay? But I will come specific into the treatment, which is specific treatment. Whenever we have pneumonia, we give antibiotic. Do you want to mention a specific name for it? No. According to hospital protocol, please. According to, you don't need to give. Every single hospital have a different antibiotic protocol for anything, okay? Don't forget that when we manage, we said step 1 is admit or not? Admit. Step 2, senior. Step 3, investigation. What are the any chest, any cough, any infection, blood, sputum, chest X-ray, okay? And then step 4 is symptomatic. Symptomatic is what? Is oxygen. If the patient is feverish, medication for the fever, and don't forget the antibiotic. Don't forget the antibiotic according to hospital protocol, okay? And maybe the patient will need fluid, okay? Just so you know, in pneumonia, typical pneumonia, PCP, TB. What is that? Typical PCP, TB. What is typical PCP, TB? What is that? Guys, listen carefully, please. If I'm dealing with typical pneumonia, because typical pneumonia, PCP, TB, Dr. Mo, what are you talking about now? So far, any pneumonia will be managed until I said investigation, the same. What do you mean? Admission, yes or no? Senior, investigation. But now, whenever I talk about symptomatic treatment, all of them will be given oxygen, yes. All of them will be given medication for fever, yes. All of them will be given antibiotic, yes. Okay, yes. But now I'm talking about the type of medication. What do you mean, Dr. Mo? If I'm dealing with typical pneumonia, how can I help you? Kind of cough, fever, sputum. Cough, fever, and sputum. What is my medication that I will give? If I want to mention medication, cotrimoxazole. What is the medication? Coamoxiclav. If you want to mention, Dr. Ahmed, medication. What is the dosage? 1.2 TDS IV plus clarithromycin 500 per oral or IV for 10 days. So if I wanna discuss the specific antibiotic I will give, how many pneumonia do I have? 3. Typical, what do you mean by typical, Dr. Mo? Cough, fever, sputum, shortness of breath, typical pneumonia. What is the treatment? I will give 2 antibiotics. Coamoxiclav, 1.2 TDS IV plus clarithromycin, 500 either oral or IV for 5 to 10 days. And by the way, usually they start the IV and then they step down to oral. Okay. Don't forget the painkiller and the fever for all of them, huh? That's symptomatic. I'm talking about now the I'm differentiating according to the antibiotic. What if I'm suspecting PCP? First of all, if I'm suspecting PCP, what is the history? So we know the history before. The history is cough, usually dry, no sputum. Sexual history, positive. IV drug abuse sometimes, and HIV. So don't forget to ask about STI screening and when were you screened for HIV. Don't forget, yeah? The patient will be homeless, doesn't have home to go to. The patient will be homeless, doesn't have home to go to. He will be using the drugs, IV, and he will be having positive sexual history. Okay. What will I give in terms of medication? Drug of choice, co-trimoxazole. Co-trimoxazole, drug of choice. Steroid sometimes is given to decrease the inflammation. So, PCP, what to give? Co-trimoxazole. Plus or minus what? Steroids. Don't forget in management here, extra. In management of PCP, to offer STI screening. STI screening. Don't forget to talk to them to bring the partner. Don't forget to advise them about sharing needle and safe sex. And what? Safe sex. So again, what is the antibiotic of a choice in PCP? Co-trimoxazole. Again, co-tri plus or minus steroid. What extra do you add? STI screening, partner notification. So ask them to tell the partner and bring the partner for investigations. Share, advise them about not to share needles and safe sex. Okay. And when you advise them about sharing needles, talk to them about needle exchange program, which is a program where we give you your new needle and we take the used one. Yeah. If it is TB, if it is TB, I have 4 medications. What are they? Isoniazid. What else? Rifampicin. What else? Pyrazinamide. What else? Ethambutol. So isoniazid, rifampicin, pyrazinamide, ethambutol. For how long? I will give all of them for 2 months. All of them for 2 months. And then after 2 months, I will only give isoniazid and rifampicin for 4 months. Again, for how long do I give the medication? I will give all of them for 2 months. And after 2 months, I will stop pyrazinamide and ethambutol. I will only carry on with isoniazid and rifampicin. Don't forget that the patient with TB and all of them. But in the TB, don't forget, it will be isolated for 3 weeks. Isolated for 3 weeks. Don't go to work. Don't go to anywhere. Isolation for 2 weeks. Isolation for 2 weeks. Stay off work. Stay off university. Stay off. If you are doing any job, anything, stay off 3 weeks. Okay? Don't forget to ask them, the TB patient, yeah, to stay in well-ventilated place. Cover your mouth, and stay in well-ventilated place, yeah? And what is now, guys, how many steps of management do we have? 7. I'm talking about the pneumonia. All of them will be admitted. Number 2, senior. Number 3, investigation. Investigation, similar. We said. Number 4, symptomatic. Symptomatic, I said mostly the same, apart from the anti, which is medication. Okay? Then number 5, and we said in TB, don't forget the isolation, yeah? Then number 5 is specialist. All of them may need to be referred to respiratory specialist. All of them will be referred to respiratory specialist, where they can do further investigation, like CT scan. Okay? Because sometimes PCP, they will need further scans, yeah? Okay, finally is the asthma. So we talk about lung cancer, mesothelioma, pneumonia, all type of pneumonia. Now, finally, I will talk about asthma. But asthma, I will consider it as the causes of shortness of breath. So now I will talk about shortness of breath. Now I will talk about cough is finished, yeah? Now I'll discuss what? Shortness of breath. So cough is finished, now I'll discuss shortness of breath. Clear, guys? Am I going fast? Sure. So for doctors who are watching the lab for the first time, is it fast?
No.
No. Slowly, yeah? Shortness of breath. Again, how can I help you, doctor? I am short of breath. That's another topic. Quick topic. I will only discuss here 2 cases. Heart failure and asthma. That's it. Heart failure and asthma. Heart failure and asthma present both of them with what? Shortness of breath. So heart failure and asthma, be careful because they will both present with. How can I help you? Doctor, I'm short of breath. Is it medicine or counseling? Medicine. Do you have any diagnosis here? I'm short of breath. By the way, heart failure and asthma, that's my diagnosis. That's the end of. Yeah, that's no. How can I help you, doctor? I'm short of breath. So it's a medicine. P1, P2, P3, maftose. Be careful because the patient who's short of breath, can anybody handle short of breath? So if you are in the hospital, you can give oxygen from the start. If you are in the hospital setting, and how can I help you, doctor? I'm short of breath. You can give the patient oxygen from the start after excluding that the patient does not have a smoker's cough. After excluding that the patient doesn't have smoker's cough, you can give oxygen, 100% oxygen. And you can put the patient in semi-sitting position. Again, how can I help you, doctor? I can't breathe. I can see Mr. Andrew are very uncomfortable. I can see you are struggling for breath. Do you have any medical conditions at all, like smoker's cough? No, doctor. Okay, I'll be giving you some oxygen, so it will help you breathe better. All right, doctor. I'll be giving my patient 100% oxygen via the mask with reservoir bag. Then give that oxygen, then start your station. Clear. Because the patient will not be able to talk when he's short of breath. Yeah. So, how can I help you? Doctor, I am short of breath. That's the presenting complaint, short of breath. What to do, guys? If the patient is saying, presenting complaint, short of breath. I'm sorry, Andrew, about this. I can see it's quite, you are struggling. Taking breath, give the oxygen. Yeah, then, can you please tell me more about it? Can you please tell me more about the shortness of breath? What do you need to know more? What more do you want to know? Since when? How did it start? All of a sudden or not? Okay? And increasing, decreasing. So explore, tell me more. By the way, some stations, if the patient is talking normally, how can I help you, doctor? I feel, I'm coming because I have shortness of breath. Always, if the patient, you don't see that he's short of breath, ask him, are you short of breath now or not? Why? Because he might not be now short of breath. And in that case, I will be asking, I will be suspecting, that's coming later, exercise-induced asthma. Exercise-induced asthma, the patient is short of breath only when he does exercise. And when he sat, he's okay. So later on, he will come to the GP. But will he be short of breath when he comes to the GP? No, he'll be fine. He had it, it's gone, and now he's coming to say, what's happening, doctor? So always, if you have a patient who's coming, saying, I'm short of breath, or I have a chest pain, very good question to ask from the start. Are you short of breath now? No, doctor. Now you know that he doesn't need oxygen. Now you know it's kind of cold, not acute case. Doctor, I'm coming because of a chest pain. Do you have a chest pain now? Because if he does not have a chest pain now, you may be thinking of stable angina. Again, that's similar more or less to that exercise-induced asthma. He has the chest pain when he does exercise, but when he has a rest, it's gone. So always, in cases of shortness of breath and in cases of a chest pain, always ask the patient, are you short of breath now? Do you have a chest pain now? Please, yeah? Anyway, coming back here. How can I help you, doctor? I'm short of breath. Can you please tell me more about it? When did it happen? How did it happen? Anything that makes it worse? Anything that makes it better? Is it increasing, decreasing, the same? Clear? After exploring shortness of breath, anything else? No, doctor. Or anything else? Like what, doctor? You remember the 5 symptoms? I think we should know them. 5 symptoms, they come together. 5 symptoms, they should come together. What are they? Shortness of breath, cough, chest pain, chest pain, chest pain. What else? Fever. What else? Heart racing, heart racing. And finally, trauma. Trauma, because trauma can lead to PE, can lead to pneumothorax, which is cause shortness of breath. So 5 symptoms, they come together all the time. When you have any case of this, please ask. Shortness of breath, after exploring, ask about
low power.
the rest. Sorry?
Low power. What? Low battery.
The charger is on the desk here, if you don't mind. Yeah. So 5 symptoms, they come together. Shortness of breath, cough, chest pain, fever, heart racing, trauma. So when you have one, ask about the rest. Okay? Okay. After excluding or after asking these questions, what do you need to ask? What should come? Flows. Yeah? But before flows, let's talk about DDs. What are the causes? What are the differentials of shortness of breath? What are the differentials of shortness of breath? The differentials of it's working. The differentials of shortness of breath. Pasha. What? What are the differentials of shortness of breath? Pasha. So again, how can I help you, doctor? I'm short of breath. If he's doing this, do I need to ask him, are you short of breath now? He's showing me. Mr. Andrew, it sound quite like difficult. You can't take proper deep breath. Yes, you can't. All right. Is it okay if I give you some oxygen? It will help you breathe well, and then we'll talk. Then I'll be giving. Do you have any medical conditions? No, doctor. I'll be giving my patient 100% oxygen via the mask with reservoir bag. Give him the oxygen. Let's talk. How can I help you? I'm short of breath. Tell me more. Explore. Then, apart from shortness of breath, any other symptoms like what, doctor? Cough, chest pain, fever, heart racing, trauma. Positive or negative, depending. And then your differentials, your causes. The causes that you are asking about, things that you are digging to know the cause. Pasha. P is 3. 3 P's. 3 P's. 3 P's. Pneumonia. PE. Pneumothorax. Again, what are the 3 P's? Pneumonia, PE, and pneumothorax. How to exclude pneumonia? Already asked, dear brother. I've asked about fever. Yeah, and I've asked about cough. PE, how to exclude PE? Already our brother asked. Chest pain, cough. But I can ask about other things in PE. Like what? Like long travel. Yeah? Long travel history. What else? Pain in the leg. What else? Medication history. Like estrogen, pneumothorax. Already asked your brother. Because I've asked about what? Trauma. So you see, the 5 symptoms that they come all of a sudden, they cover plenty of differentials already. Without thinking of differentials, already the 5 symptoms covered some differentials. A is for anaphylaxis and asthma. Or because there is A at the end and the A here, so make this asthma. A is asthma. A is asthma. A is asthma. A is asthma. What do I need in asthma cases if I'm suspecting asthma? Guys, don't forget, because if I'm suspecting asthma, the presenting will be shortness of breath. But what factors do I need to ask about? I will need to ask about what? Allergy. About what? Allergy. I will need to ask about exercise to exclude what?
Exercise.
But an exercise induced the asthma. Will he come with shortness of breath? No, he will say, doctor, I'm fine. Usually when I do exercise, I have shortness of breath. Allergy is important in asthma? Yes. I will need to ask a family history. What? Of asthma. Important? Yes. I will need to ask him about pets. What else?
Carpet.
Carpets. What else?
Occupation.
Yes, occupation. Okay, pets, carpets. What else? Smoking. People, if they smoke around someone who's asthma, it can induce. What else? Sorry?
Cold weather.
Cold.
Cold weather.
Cold weather. So pets, carpets, cold weather, dust. So all these are factors. Why Dr. Modu give us this? Because I'm just trying to be specific now. So all of them, patient is coming with shortness of breath. Explore 5 symptoms. Pasha is the causes. And with every one, there are some differentials. And with every one, there are some risk factors. S for smoker's cough. S smoker's cough. And what is the only thing that I want to ask about? Smoking. Smoker's cough. What do you want to ask about? Smoking. And you can ask directly. Have you been diagnosed with a condition called smoker's cough? COPD. H for heart failure. H for heart failure. H for what is the presenting complaint? Shortness of breath. How can I help you, doctor? I'm short of breath. Heart failure. What are the things that you want to ask about in heart failure? Okay? In heart failure, the shortness of breath is more when they lie flat. Decrease when they number 1. So number 1, make sure you explore the shortness of breath. Is it more when you lie flat? Yes, doctor. Is it more when you do exercise as well? Yes. Heart failure, when they walk, they feel more short of breath. Yeah. So when they walk, when they go to work, when they walk, when they do something, they have it as well. More when they lie flat. What else in heart failure? Swollen legs. Swollen legs, because always they have edema. So swollen leg. Swollen legs. What else? They will have history of medical condition like heart attack. So heart attack on top of heart attack on top of heart attack, they end up by heart failure. So history of heart problems like what? Like heart attack. History of heart problems like heart attack. History of heart problem like heart attack. Okay. What is the final A? Anaphylaxis. Anaphylaxis, can it lead to shortness of breath? It's one of the most common causes, shortness of breath, anaphylaxis. And anaphylaxis is severe allergic reaction, acute severe allergic reaction, and this is Simman case. We don't need to even discuss it here, Simman case. And you can ask here about any rash, nearly finished. Any rash, you can ask here about rash. Rash, any rash anywhere in the body, swollen tongue, mouth, face, rash. Swollen tongue, swollen mouth, swollen face. So that's for anaphylaxis. Rash, swollen tongue, swollen mouth, swollen face. So these are all the causes for shortness of breath, but I mainly need heart failure and asthma, the 2 cases I will discuss. So how can I help you, doctor? I'm short of breath. If the patient is short of breath, can you give him oxygen from the start? Definitely. What if the patient is not showing you that he's short of breath? Ah, doctor, I feel I had some shortness of breath. Always ask, are you short of breath now? No, it's fine. Then, apart from shortness of breath, explore first shortness of breath. Then, anything else like cough, chest pain, fever, heart racing, trauma? Yes, no. Then, you know your differentials are PASHA, P, 3 P's, pneumonia, PE, pneumothorax, A, asthma. So here, ask about any risk factor. Just before the shortness of breath, anything you think might have triggered it, anything you might have started it, like dust, do you have pets at home? Yeah, carpets at home, the type of floor at home, cold weather. Okay, then smoker's cough, any medical conditions you've been diagnosed with, like smoker's cough, heart failure, which by that you will ask about the conditions of breath, any swollen feet, any heart problem. Yeah. The shortness of breath, is it more when you lie down? Is it more when you walk? And past history of MI, usually. Anaphylaxis, rash, swollen tongue, swollen feet. Now, P2, P3, maftosa, P2 quickly, have you had this shortness of breath before? Past history of presenting complaint. Past history of complaint. It will be positive in asthma. Yes, doctor, I've had it before, doctor. If the patient said, yes, I had it before, what to do? Explore. What happened? Was it diagnosed? Are there any medications to explore? So past history of presenting complaint usually will be in asthma cases. Any medical conditions? Medical conditions. Then P3, DESA, diet, exercise, smoking, alcohol. Is it important? Yes, it is important. Because shortness of breath, exercise induced asthma, that causes exercise. Shortness of breath may be COPD, smoker's cough, smoking. Yeah? Shortness of breath, diet, important or not? Not important. Okay? So it's not important. So smoking and exercise and alcohol, you ask. But diet, no. Because if you go to diet, I eat healthy. What do you mean by healthy? You know, I eat fruit. So smoking and alcohol and exercise is a must. Now, maftosa. Are you on any medications? Allergy, family history. Okay? Medication, allergy, family history. Well, travel, yes, because of PE. PE, travel, long travel, for example. Have you done any long flights? Occupation, yes, occupation is important. All right, I'm trying to now tell you what is relevant, okay? So, yeah. That's it. So that's the history. Difficult? Shortness of breath. Management, we will discuss now the management. And I said to you, I will discuss management of what? Of asthma and heart failure, and that's it. So these are the two cases I need. Asthma and heart failure. The two cases we need in shortness of breath. So, heart failure. So heart failure management. How to manage heart failure. First of all, if I apply the station on the structure. How can I help you, doctor? I'm short of breath. Tell me more about it. Are you short of breath now? Yes, doctor, I'm short of breath now. Started doctor 3 weeks ago. How? Doctor, when I'm lying down, usually I feel short of breath. When I walk, when I work, that's the positive, yeah? Okay? When you go to Pasha, when you go to cough, sorry, the 5 symptoms. Cough, no, doctor. Sometimes it's acute if there is bilateral edema, okay? The patient, palpitation, heart racing, yes, doctor, the 5 symptoms, okay? Chest pain, sometimes, doctor. Then go to the positive finding in this case. Anything else? Swollen legs, doctor. Anything else? Medical condition, MI, doctor. Yeah? Now, how to manage it? Management. Management, 7 steps, we know. Number 1, admit or not? 100% admission. Number 2, investigations. What are the investigations that I will do in such case? Always, whenever you talk about investigation, blood, urine, stool image, blood. For blood count. Heart attack marker is a must. Do not forget heart attack markers because it's very important and the patient will have past history of MI and its heart attack markers is a must. Okay, clotting profile, thyroid kidney function test, very important. And don't forget the specific test for heart failure, BAMP, which is B, atrial natriuretic peptide. Atrial natriuretic peptide. Don't forget, this is the heart attack marker. Sorry, heart failure marker, okay? So, 2 markers we need. Heart attack marker and heart failure marker. The heart failure marker is called atrial natriuretic peptide, okay? BAMP. Step 4 is symptomatic. This patient, what do you wanna do? Dr. Ahmed, symptomatic treatment. Sitting position or semi-sitting position, oxygen, and because heart failure there is fluid, always furosemide, 40 mg furosemide to decrease the swelling, okay? And don't forget that the heart failure is mainly caused because of high blood pressure. What do you mean, Dr. Mo? The heart is pumping against high blood pressure. If there is something pumping against high pressure, what happened? The work will increase and then it will become weak. This is the mechanism of heart failure. So always you will give them something to decrease the blood pressure. Always they will be on medication like ACE inhibitors. Always they will be in medication ACE inhibitors to decrease the blood pressure. Always they will be on aspirin to decrease the clots because there always high possibility of clots. Okay. So step 4 is symptomatic plus. Step 4, symptomatic and lifestyle. So don't forget, if the patient is a smoker, talk about smoking. If the patient is having bad, for example, having low, if he's having high salt intake, so he needs to have low salt intake because there is a risk factor which is high blood pressure. High blood pressure. So in asthma, diet is not important. But in heart failure, diet is important because there will be high blood pressure, okay? Specialist, step 5 specialist, echo, cardiologist. So echo, cardiologist, very important, specialist, echo, and cardiologist. So management of heart failure, admit or not, admit senior, yes, investigations, blood, 2 markers important, heart attack markers and heart failure markers. Heart failure markers, atrial natriuretic peptide, heart attack markers, troponin, okay, and plus everything else. Step 4 is symptomatic. You want to give oxygen? Yes. Do you want to give furosemide to decrease the fluid? Yes. And this patient, because of heart failure, most important factor is high blood pressure, so ACE inhibitors. And always talk about the lifestyle, smoking, diet. They should take low salt intake. And specialist is cardiologist, who will give further management, okay? And we'll do echo, further echo, okay? Now, management of asthma. Management of asthma. In asthma, I have 2 cases. 2 cases, acute asthma, and I have exercise-induced asthma, okay? 2 cases, and that's it, we finished. So 2 cases and we have finished. Exercise-induced asthma and acute asthma. The exercise-induced asthma, will the patient be short of breath on admission when he comes to the GP? No, the patient will be fine. How can I help you? Doctor, I'm coming because I have some shortness of breath. What is the golden question when the patient said I have shortness of breath? Are you short of breath now? No, doctor, I'm not. Tell me more about it. How did it start? When did it start? All of a sudden, increasing, decreasing, gradual. Am I making any sense? After exploring shortness of breath, ask about the 5 symptoms and then go to PASHA. In PASHA, the patient, what is the case? You're suspecting asthma. So in PASHA, in asthma, PASHA, in the A, what to ask about? The questions underneath, to be specific. Dust, carpets, exercise. Yes, doctor, it's increasing. Want to do exercise. What do you do, doctor? I want to have a rest. It gets relieved. Family history, family history. And that's it. Have you had this before? P2, medical condition. P3, do you need diet? No. Do you need exercise? Yes. Smoking? Yes. So, relevant history. Smoking, exercise. Haemoptysis, medication, allergy, family history, and that's it. Alright? Now, when you manage, what to do? Guys, exercise-induced asthma, nothing but advice. Exercise-induced asthma, nothing but, what do you mean, Dr. Mo? Nothing but advice. In exercise-induced asthma, I will follow the steps. How many steps do you have? 7 steps, yeah? Step 1, do you need to admit? No. Exercise-induced asthma, do you need to admit? No. So the patient will go home. It's a GB kind of case. Senior? Yes. Investigations. Very important investigation will be done in this patient. PEFR. PEFR. While he is running on the treadmill. What is the PEFR? Peak expiratory flow rate, which is this. PEFR, yeah? PEFR. Peak expiratory flow rate will be done while he is running on a treadmill. While he is running on a treadmill, and we will do spirometry. Spirometry, okay? The patient. Now, the patient will be advised. What are the advice that will advise? Number 1, exercise indoors. Exercise what? Indoors. Number 2, I will tell the patient The advice, when does he have the asthma? During exercise. So, number one, exercise where? Indoor. Number two, I will tell him, before exercise, use the inhaler. Use the inhaler. Inhaler, salbutamol, reliever. Before the exercise, use the inhaler. Okay. And warm up. And warm up. So before exercise, use inhaler and warm up. And exercise indoors. And cover your nose if it's cold. If it is cold weather, cover your nose. So again, exercise induce the asthma. What is the management? In brackets, just advice. Just advice. I will tell him the reason why I'm having this is because when you do exercise, you develop the asthma. What should I do, doctor? What exercise do you like doing? Ask him first. Then tell him you should exercise indoors. Before exercise, you will have inhaler. Before exercise, you will warm up. And then in the exercise, avoid the long-term exercise because that's when he has the asthma. Okay? So it's mainly about advice. And safety netting, if shortness of breath getting worse, and if it's not stopping after you have a rest, okay? And if bad, come back to the A&E right away. Okay, what about if the patient is coming in acute asthma attack? In acute asthma attack, okay? In acute asthma attack, this is Simman case. This is what? And that will be discussed in the Simman. Again, this is what? Simman case, and that will be discussed in the Simman. Don't worry, it is a Simman case discussed in the Simman. So what is the first case in asthma we said? Exercise in the asthma. Management is advice. What is the second case? Acute asthma attack. Hi, how can I help you? I'm short of breath. I can't breathe. This is what? Simman. Emergency. Will be discussed in the emergency. The third, which will be discussed here, it is a patient who presented to the hospital. Listen carefully. 3 days ago with acute asthma attack. Now he is stable. Now he is managed. Go and talk to him. Make sure he is fit to go home. So what does that mean? It is a case of counseling. Is he diagnosed asthma? Yes. But your job is to go and make sure he is fit to go home and explain to him the medication. Again, what is the third scenario? The third scenario is a patient who presented to the hospital 3 days ago, diagnosed the asthma, okay? Managed, yes, managed. Stable, yes, stable. But go and make sure he's fit to go home and explain to him the medication he will be on. That's it. This is the case. So, do you want to take history? No. It's brief. How can I help you? No. You've seen him before. He's been admitted. So, I can see from my note, Mr. Andrew, that you've been admitted in the hospital with acute asthma attack. Yes. Are you short of breath now? The patient will say, no, doctor. Well, the consultant think that it's time for you to go home, and I'm here to make sure that you are okay and you are fit to go home. In this case, the question will say, do the BFR. Do what? Do what? The BFR. This is the question as well. Do BFR. So, you will say to him, now I'm here to make sure they are fit to go home. This is an instrument that I will show you how to use it because we need to make sure they are fit to go home. This is called what? This is called what? Peak expiratory flow rate. What it consists of? Mouthpiece. Mouthpiece, yes. Pointer, can you see this? Pointer, 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 and cylindrical place. So cylindrical part. So I have the cylindrical part with what? Pointer. Can you see this? This small thing. Pointer, you see? Pointer. And you have the mouth part. Okay? So you will be sitting comfortably, sitting in position with your back straight. Take a deep breath. I will make sure that the pointer at 0, you see? The pointer, you see this pointer, yeah? Yeah, I will make sure it's here at 0. Sit comfortably with your back straight. Take a deep breath. Guys, he will blow here, so I see how far that pointer will go. So sit comfortably. Bring the pointer till the end, till last here. Take a deep breath. Make your mouth tight seal with this, then blow as hard, as fast as you can. You see? You see the number here? You see this pointer? What is the number?
600.
600. And he's saying to you that the normal for me is 600. 600. That what should be the normal. But the patient is okay to score 75% out of his normal. What do you mean, Dr. Mo? So 600 is the target. If you score 450, which is 75% out of your normal, still fine. You can go home. So this is the pointer. This is the cylindrical part. This is the mouth part. Again, think about it. First, the patient should be sitting, back straight. The pointer should be at 0. Your mouth will make a tight seal, but take a deep breath in, then mouth, tight seal, then blow as fast as you can. Make sure that your finger is not blocking this pointer, so it moves freely. Now, you will be giving this chart. This chart, BEFR chart. Is it clear on the camera?
Yes.
This chart, how many group of lines? 2. There is a group here, a group there, yeah? One is for male, one is for females. Clear. One is for males, one is for females. There is 2 lines. One is what he scored, 2 is the age. So this one is for the age. This one is for what he scored. For example, am I a male or a female? I am a male. So I will choose that one. Then that one. Then what did I score?
600.
600. That's 600. How old am I? I am 35. So 35 line straight, 600, and then that's my line. That's my score. Okay? And you should score up to how much? 75% out of your normal. Okay, so the top one is the men, that one is the women, males and females. Okay, so you will have this chart. You will have this chart. Okay, the normal again. Look, what's how old are you, doctor?
25.
So look, 25 for example. Look, 25. Which one is the male? The lower or the upper? The upper. So 25. I will go here. Here. What is the height?
100.
Look, this is the height. So 160, 167, 162. So 160, this line. Here. And 25 years old. So it should be 550. Can you see, guys? Then that's his normal. But he's okay to score even 75% of this. For example, what's your name, doctor?
Hussein.
Dr. Hussein, look, which one is the males? The upper one, yeah?
Yes.
The upper one is the males. And how many lines here? 5, 6 lines, depending on the height. Depending on the Dr. Hussein, for example, he's 183 cm. So this line, you see? How old is you? Are you? 30. For example, so I will go with 30 till I meet which line? The height line.
Yes.
That's it. His normal is 640. So he's okay to score 640 or even 75% of this. Okay. So that's the big flow meter. Guys, did you understand it?
Yes.
Okay.
Very
So I will put it here. So 2 lines. One is for the score. Yeah. One is for the age. How many group of lines? 2. One group of line here for males, one group of line for females. And these 3, 4 lines, depending on height. So, for example, here is 35 years old. My height is 160. For example, this line is 160. So I will go here 35. I am a male, so this is the male part. Until you meet, my height is this line. Then this point, go there, this is 650. So this is my normal, and I'm okay to score even 75% less. So you will let him sit down again. What is the station about? Two things. Assess he's fit to go home. By that, you will use PFR and explain to him the medication. So I will say to him, I can see from my note that you had asthma 3 days ago. Yes, doctor. How you doing now? I'm fine. Are you short of breath? No. I'm here for two things. To make sure you are okay to go home and explain to you the medication. So first of all, let me explain to you how we're going to use this so we make sure that you're okay to go home. This is called PFR, peak expiratory flow rate. This is the mouthpiece. This is the pointer. Yeah, and it's cylindrical part. Your finger should not touch the pointer. Sit comfortable, sitting, deep breath, tight seal, blow as hard and as fast. Then you guys count. You guys count. This is the number that you will check. But how to get his normal reading? How? From his age, crossing the line of his height. Again, his age, crossing the line of his height. How many group of line do we have? Two groups, males and females. If he's a male, the upper group. And how do I match this age with which line? With his height. And then go forward here. This is the normal line for him. The normal reading. But if he's okay to score 75% less. Now, he's okay to go home. He scored the score or within the 75%. Now I'll advise him when he goes home. When he goes home, to do what, doctor? To do what? To do this twice. Twice a day. To do this what? Focus. He will do this how many times a day? Twice a day. We need how many measurement? Two measurement. Two measurement, yes. But in each time he will measure it, he's not gonna do it once. He's gonna do it 3 times, and he will choose the highest again. The patient is okay to go home now. The reading is okay, he will go home. We need to assess him when he goes home. Is he improving? Or is he the same? Or is he getting worse? So I will tell him, you will do this test how many times? We need, how many readings do we need? How many reading? 2 reading. 1 in the morning, 1 in the evening. But in every reading, you're not gonna do it once. You're gonna do this test 3 times, and we'll choose the highest reading. Then we will see if the reading, if the lines like this, if this is the readings, means he's improving or he's getting worse. Improving, do nothing, carry on. What if the line is like this? He's the same. So you will come for follow up. What if the line getting worse? Come right away, because he's getting worse. So after I make this test, and now he's okay to go home. When he goes home, I will advise him about the asthma diary. And I'll ask him to do this test. How many reading do I need? 2 reading a day. In every reading, how many times should he do this? 3 times. And he will pick only 1 reading, the highest or the lowest. And he will plot it on a chart. If it's going up, that means that he is improving. If it's going down, he's getting worse. If it's the same, he's gonna come to us to see what's happening. If it's getting worse, come right away. If it's improving, he doesn't need to come. Now, what are the medication that I will give him? I will give him salbutamol. I'll give him salbutamol nebulizer. What is that salbutamol nebulizer? You need to explain to him. Guys, it will be the same as this, but blue. The same as this. The same as, inhaler, The same as this, but what is the color? Blue. So I'll give him salbutamol inhaler. What else? Steroid as well. I will give him the same as this, salbutamol inhaler. It has salbutamol, but the color is blue. This is for steroid, yeah? So the content here is not salbutamol, okay? And I'll give him tablets. So I will give him 3 things. 2 of them inhalers, 1 of them is blue, the second is brown, and tablet. So number 1, I will give him salbutamol inhaler. I will say to him, this is called reliever. This is called reliever. What do you mean, doctor, by the level? Take it when needed. Only when you have shortness of breath. Only when you have shortness of breath. This is the blue one. You will take it, or you will buff 2 buffs maximum. How many times? 4 times. So 2 buffs maximum a day, 4 times. When do you take it? Reliever. When needed, as required. The second, I will give him the second inhaler, brown inhaler. Brown inhaler called beclomethasone. Called what? Beclomethasone. The beclomethasone will be given 2, 2, 2. So this will be given for 2 weeks, twice a day, 2 buffs. So 2 buffs, how many times a day? Twice a day for 2 weeks. Is that when needed or regular? Regular for 2 weeks. So 2, 2, 2. What do you mean 2, 2, 2? 2 buffs, twice a day for 2 weeks. This one, is that when needed or regular?
Regular.
Regular. What about the same one but blue?
When needed.
That's when needed. Salbutamol inhaler. What is the third medication I will give him? Prednisolone. 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 1 tablet. 1 tablet. 1 tablet for 3 days. Okay? So how many medication this patient will be given when he's going home? 3. Number 1, salbutamol inhaler. What is the color? Blue. Blue, blue. How often? When needed. When required. PRN. The second is brown. 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 Beclomethasone inhaler. 2, 2, 2. 2 buffs. Twice a day. 2 weeks. The third is medication tablet for 3 days. Okay? So make sure when you give him the inhaler, explain to him. This is the medication. Check the expiry date. Check what? The expiry date. Okay? Always you can take it. Look. Yeah? Shake it. Put it in. Okay? Check the expiry date. Check the expiry date. Check the expiry date. There's a cap here. Okay? Shake it. Take the cap. And then sit upright. And then type. And then. Clear? So again, how to tell him to take this. Number 1, check what?
Expiry date.
Number 2,
Shake.
3,
Remove the cap.
remove the cap. 4, make a
Yes.
tight seal. Make a
Seal.
tight seal. Make a
Tight.
tight seal. Done?
Take your breath. Hold.
So press the canister and then take deep breath. Clear? So that's for the salbutamol when needed, and that's for the brown. That's when how often do you take it? 2, 2, 2, and then the medication. Clear? Just one thing, that the side effect. What is the side effect of the salbutamol inhaler? Heart racing. What is the side effect of the steroid? Fungal infection. So always say to him, this medication has some side effect. You might feel some heart racing. Don't stop it. This medication, but always advise him, if it's a continuous heart racing, if it's you feel dizzy, come right away to the hospital. This medication is the beclomethasone. It's a steroid, so high risk of you having fungal infection. So always what? Rinse your mouth with water after you finish it. The prednisolone tablet steroid, long term, can lead to some side effect, but as you will only use it for 3 days, you're not gonna develop these side effects. Guys, and how to finish your station, as I mentioned, you will finish the station before the safety netting. Don't forget how many times does he need to do this, how many reading do we want? 2. So he will do twice, but every time will be done 3 times. We'll take the highest, improving, same, decreasing, and always safety net for shortness of breath, chest pain, come right away to the hospital. So 3 asthma station. Number 1, exercise induce the asthma. Management is advice. Number 2, acute asthma. Simman. Don't worry about it. Simman. Number 3, patient was in the hospital, had asthma. He was treated, he's going home. So you will do 2 things. Assess if he's fit to go home or not. Explain the medication. Assess if he's going to go home or not through this. It should be either the normal level or less. You can accept 75% of the normal level. How do I know? There's a chart will be given to you. This is chart, reading against age. And 2 blocks of lines, 2 blocks of lines. One for females, one for males. And every block of line depending on the height. So choose the line with the right height, choose the group of the males or the females, then the line of your right height, then the age. Go up until it's meeting, then go there to see the reading, and you can score even 75% less. If he's okay to go home, he will go home, but we'll advise him to do this to see if he's improving or not improving, or the same or getting worse, and then give him the medication, which is salbutamol inhaler blue, and the beclomazone inhaler brown, and the medication, and always safety net him, and always tell him about the side effect. Thank you very much.